welcome to the first Wellbeing of Women webinar. I hope we've got a full audience today. I'm Janet Lindsay and I am the CEO of Wellbeing of Women. Thank you so much for joining us today, and also thank you to our brilliant speaker, Mr. Ed Coates, who's consultant obstetrician and gynaecologist at the Royal United Bath Hospital, and he's also a specialist in fertility. Before we start, I would like just to cover a little bit of housekeeping. We are recording this, so if you want to turn off your video, now is the time to do so. We are also asking you to add your comments on chat. We did actually ask everybody to submit questions, and Ed will cover these later on in his talk. And we do hope we'll have time to cover more at the end too. So do add your questions if you want to the chat section. So without further ado, who are Wellbeing of Women? Well, sadly, most of you will never have heard of us, but we are in fact the UK's foremost and only women's health research charity. We're 56 years old, with some of the country's brightest and best doctors, researchers, scientists, midwives and nurses. I said many of you won't have heard about us, but I can absolutely guarantee that you will all have benefited from our research at some point so far in your lives, because it's used every day in doctors' surgeries, in hospitals, antenatal clinics, schools, up and down the country and beyond. Here's just a few examples of how we've had impact. I guess many of you here today are pregnant or hoping to become pregnant, and therefore you'll be taking folic acid supplements. What you won't know though is that the important role of folic acid in pregnancy was one of Wellbeing of Women's very first research projects. Our research has also led to the use of ultrasound in pregnancy to detect all kinds of things, and we also help build the foundations for neonatal intensive care. We've done a huge amount more. Please go to our website and check if you want to know more about us, and I hope you will. Until coronavirus struck, we had 30 projects on the go. 2/3 have stopped as of today, and the doctors, scientists, midwives, nurses are all back on the front line fighting the pandemic. We are so proud of all of them and everything that they're doing. We do want them back because without research, there's going to be no new breakthroughs so badly needed in women's health, leading to new treatments, cures, tests and preventions. Just a small fact is that less than 2.1% of publicly funded research is in women's health and reproduction. Please help us to make sure that our researchers can return to their work by making a donation. There are details on our chat, and you can also go to our website. I'm sure you must be aware that all charities are really suffering, and although the government has given money to charities, most of that is going to frontline work. Now, ours isn't frontline work yet, but if we don't raise money in the next few months, then some of our research just simply won't be able to continue, and we rely on our friends and supporters. So although we're giving you this talk free of charge, it would really help us if you could go and donate. Thank you so much for listening. I'm going to hand over to Ed now. Thank you.
Thanks, Janet. That's a lovely introduction, and I'm very grateful to the charity for allowing me this hour to spend some time talking to people who, during a very challenging time, will be, I'm sure, very concerned about what COVID-19 and the novel new coronavirus means for their pregnancy in particular, and also people trying for pregnancy and what the many months ahead will mean. So I'm an ambassador for the charity, as you know, Janet, and I've been involved with the charity for over 10 years. And so I'm proud that to be part of this very first webinar that I believe we've done in what is fairly unusual circumstances. So I hope you find it useful, and please do use the website, the Wellbeing of Women website, which is a great information hub for patients. And we'll be giving you at the end some useful places where you might want to look at resources, which other than the chat today, where you can get more information from as well. But I wanted to start by sort of looking at, I guess, initially at the current situation. I am working in the NHS in what you would call the front line. The front line is often described on television as being the people in intensive care, but I believe anybody working in hospitals today is on the front line, in fact, whether you're a hospital porter or a hospital doctor or an administrator, anybody in the hospitals or indeed in social care is providing those vital frontline services. And maternity services don't change really, despite the fact that we have this awful pandemic surrounding us. Maternity still has to keep moving, and as does antenatal care and postnatal care. And so it's an extremely anxious time for many of you, as it is for the staff who are trying to provide excellent care. We are obviously now in a position where we're in lockdown now for a further 3 weeks. Many of you will have been isolating for 3 weeks already. We heard around the 16th of March from the government that pregnant women were particularly vulnerable and a vulnerable group, and I want to talk a little bit about that today. But let's just start with the virus. It obviously originated from the Hubei province and the city of Wuhan, which has a population of around 12 million. It is one of the 7th coronaviruses to have transferred from animals to humans, and it attacks the respiratory system, the lungs particularly. What we have found out with time is that this has spread around the world and that we've had to change our daily lives significantly. Now, for pregnancy, particularly many of you will be very low risk and very normal in your pregnancies, and others of you will be more complex and need more detailed care. So the presentation today is going to be difficult to cover everybody's individual cases, but I wanted to focus really on what we know about COVID-19 so far, and particularly what that means for you potentially in your lives. But first of all, I just want to share with you my first slide, which is to just really reassure you that there are some key priorities for us as a group of doctors providing services. I want to start with this first slide. Our goals in the hospital, in maternity services, are to reduce the transmission of COVID-19. That's between staff, between patients, and to ensure that people can continue as normally as possible with their maternity care. And we need to make sure that despite this coronavirus pandemic, we are providing high quality, excellent and safe care to all pregnant women throughout the time that we are under these unusual conditions. So that is an absolute priority for us as a group of professionals, midwives, doctors, nurses, and all of the staff involved. Now, what we do know about the virus and its transmission, and many of you may know some of this already, is that it's transmitted really in two ways, two routes. Directly, so that involves being in close contact with somebody within 2 meters, where respiratory secretions from the eyes, the mouth, the nose could enter into the airways of the other person. And then there's the indirect route, which you could contaminate yourself with the virus from touching things such as surfaces, objects that carry the virus, other people's hands, shaking hands, but then yourself infecting yourself with the virus by then touching your nose, your mouth, your eyes, and the virus accessing the airways in that route. So just going back to that slide, can you see that slide? Can everyone see that? I think that should be visible to you. Let me just show you that. So that is the two commonest ways of transmitting the virus. We also think that obviously human-to-human transmission is key, but we think as well that it's probable that there can be what's called vertical transmission in pregnancy. This is really come from a few reports from China, which have suggested that you may be able to transmit the virus in utero to the baby, which means that some people have found that there's antibodies in the serum of the babies that are born, which means that they will have some immunity to it. This again is very, very early days. You have to understand with research and with data and with established evidence, it takes many months sometimes for this to come through, and we've been working at an incredible pace to get a lot of this information. And this has been, we have to be very cautious about small groups and numbers of studies that are suggesting things. And also a lot of the data initially has come from China, which has proved challenging in so many ways, not only for the translation side of things, but also the numbers of cases which have been duplicated in cases and published in different journals. And so it's quite hard to get very, very accurate details. What we do know is that the virus has not been found in amniotic fluid, it's not been found in vaginal secretions, and it's not been found in breast milk. But we also have to say this is a evolving landscape, and so these things can change day to day and week by week. And so we will need to obviously keep pace with the changes as they come and try and look around the world at the data and analyse it with caution. As a group of pregnant patients, you will be wondering, what does it mean for me? Because I'm pregnant, am I more likely to catch it? No, we don't think so. We don't think because you're pregnant, you're more likely to catch the virus. Absolutely not. The thing that most people will probably get is a very mild flu-like symptoms if they were to get it, maybe moderate flu-like symptoms. And some of you may not even know you've had it. And that will be the vast majority of people. A few people may develop a cough. A few people may feel feverish. And at the more extreme end of symptoms, people may feel breathless. And if you do feel any of those symptoms and feel unwell, and feel unable to cope, then you should obviously urgently contact your maternity services. But the general advice is that if you have a mild flu-like symptoms, is to isolate for 7 days and to stay at home. We don't know entirely whether the coronavirus has an impact on the fetus in utero, but if you look at SARS and other common viruses, it seems to be behaving in a very similar way, and most of the evidence would suggest that we think babies are not impacted on in the uterus, inside the womb, while you're pregnant. If, however, you feel that you yourself are becoming unwell, then you should obviously you should make sure that you contact your maternity team, and you will have ways of doing that once you've booked with a midwife. The reason you have been placed as a vulnerable group by the government is because the immune system in pregnancy, and we've known this for years, in general will work very differently. So it works differently to somebody who's non-pregnant, and that can mean that infections can be harder to fight, but not in all cases. And certainly there's no suggestion really that because you get coronavirus you're going to get it worse than someone else because you're pregnant. As I said, the vast majority of people will really only ever exhibit mild symptoms. So it's really quite uncommon to get the severe symptoms that you're hearing about in the news, about pneumonia, for example, really severe breathing difficulties, needing extra oxygen. But in some rare cases, patients may develop those symptoms. And if you feel that you may not be recovering within that fixed 7 days of allotted to you in terms of isolating, if you do have symptoms, it is recommended that you do seek help. Now, I know there'll be a lot of fear as well about your babies and what this means for your babies. Now, some people who are not pregnant but thinking about pregnancy may also be concerned, should you be trying for a pregnancy? As I speak to you today, we don't really have evidence to suggest that this will create any problems with early fetal loss, any early miscarriages, which is great. We don't believe that this virus harms babies in the uterus, as I've already said. And so for many of you, this is not something which we believe in the first 12 weeks of pregnancy is going to cause huge problems for the vast majority of people. And so we're certainly not telling people to not try to get pregnant. That is something as well. And we fully expect, in fact, probably to see a baby boom after the lockdown has finished in the months ahead. There is possibility, as I've said, of transmission of immunity to babies, although we're not sure of the significance of this yet. Coronavirus itself, we don't believe, precipitates early labour. But if you were to become unwell and be admitted to hospital and require some additional help, then decisions may be made to make your care improved, that an early labour may be something which you'd be advised about. But those decisions are individualised around the patient, but we certainly don't believe it's going to cause lots of early labours, and that's not what we've seen from the data so far. So that's really where we are at the moment in terms of the pregnancy. Now, from a physical point of view, many of you will be wondering, I suppose, what it means for your bodies if you were to catch the virus. Physically, it's very important to remain in as good a health as you can be. And whilst we're not out and about and going to meet people and to sort of disappear into sort of crowded places where you could become unwell, it's important to look after yourself. So that means keeping yourself well hydrated, keeping yourself well rested, and also eating well. So I just want to share a slide with you, if I can do that for, let me just see if I can bring that across. Okay, so the important points really are, I think, physical health. It's important to take your daily exercise. It's important to do that hour of exercise a day. We know pregnancy is physiologically does make patients more susceptible to getting to get a blood clot, for example, as opposed to somebody who's not pregnant. And so it's always important, whenever you're pregnant, whether we have a coronavirus pandemic or not, to remain mobile, to remain active, going about your normal things. Now, that's harder to do when you're locked in your homes and you can't go out and do the normal things. So we are, by the nature of this pandemic, taking less exercise. So we really encourage you to remain active, to take your daily exercise. Of course, we will be more sedentary. If you are more sedentary, particularly as we approach the summer with the hot weather, it's important that you do stay hydrated. One of the key things for pregnant patients and pregnant women is to make sure that they obviously self-isolate and socially isolate away from any risk, but take those precautions as strictly as you can. The 2 meter minimum is around the direct route of transmission we've talked about, and the indirect route of transmission really can be prevented by absolutely strict adherence to hygiene and hand washing. Monitoring your baby's movements is an absolutely crucial part of any pregnancy, but even more so during this time, to make sure that if you have any concerns, that you obviously are keeping very, very close eye on the baby's movements throughout. If you have any concerns about yourself, your own health, or your baby's health, then please do contact your maternity teams. I'm aware, working in the hospital, there's a lot of anxiety around coming into hospitals, and there's often a misconception, I think, that the hospitals are a place where you are going to be at more risk. Of course, you will be anxious if you need to come to a hospital, but please do not delay any concerns that you may have regarding your own health or your baby's health, particularly movements. Contact your maternity team. We have completely changed the way of working in hospitals. We have different zones. So we have, in my hospital, we have a green zone and a red zone. So we have a zone where we have gynecology services and maternity services for anybody who is healthy and has no symptoms. And we are running routine antenatal clinic appointments, essential scans, essential tests, essential investigations. We're having to change things dramatically in the way we do that, and that has all been adapted. And I've been incredibly impressed by the resilience of the people in the hospitals working to change things. I have found that most patients have been quite understanding of the extra delays that sometimes are involved with coming to the hospitals during the times that we have. For example, if you had a routine antenatal clinic appointment that was required in your pregnancy, it may be possible to delay it if you're self-isolating, but it may be something that you can't miss and you do need to come to hospital for. And so what I would encourage you is to not miss appointments because you're worried about going to the hospital. It is a really important part of antenatal care. We know from lots of research over many, many years that good antenatal care, good care in labour and good care after you've had your baby are absolutely critical to good outcomes. So it's really, really important that you don't miss appointments, and also don't delay any assessment if you have concerns about your physical health. Now, we talk a little bit about physical health, but we've also talked about mental health. And I think particularly pregnancy is a difficult time for many families, many couples and people going through this either on their own or separately. And particularly now that you're isolating yourselves away from friends and family, it can be extremely hard. There is support out there. I've put a website link there for you to look at in terms of supporting yourself. We're staying in touch with you through this wonderful webinar today, but please do use Zoom and contact friends and family and try and keep the conversation going. It's all about keeping the conversation going, and I think that will help you stay positive because it's quite easy, I think, with what's happening on the news day in, day out, and hearing the bad news, to forget actually that we're existing. We are still requiring that very normal human instinct of social interaction. And so I would do it as safely as you can through some of those methods that I've mentioned there: Skype, Facebook, FaceTime. You'll be probably better at it than I am. I think financially, this is a difficult time for people at home as well. People have lots of concerns about jobs. I'm very fortunate in that I have a job in the health service, and I'm very, very lucky as well that, you know, I've got a wife who's a midwife who's very supportive of me going to work, and having that understanding. But I know for some of you it won't be as easy as that, and you will be wondering about the future and jobs and income. And so it's very important, if you do suffer with anxiety or depression or mood disturbances, you need to, I think, engage as well with your community midwifery teams. If you're feeling low, feeling in despair, not sure where to turn, there is support there. We know, and we've seen, sadly, the amount of abuse does go up with difficult situations, like being confined at home as we are, and we have seen an increase in that. So there is help out there if you're finding your home situation is not good. But please look after your physical and your mental health, because they're both as important as the other. What can be done, I suppose, to reduce your risks? Socially distance is key. Staying in touch with people to keep yourself mentally upbeat. I think my biggest concern and worry is that people will miss appointments and not trust going to the hospitals. So I do think that's a really key thing for you to be thinking about as you go through. I want to talk a little bit about what to expect as you go into hospital, because some of you will be in the latter half of your pregnancies. Now, we think COVID-19 coronavirus is probably more of a risk as you get further on in your pregnancy than in the early stages of a pregnancy. And so when you're 28 weeks and beyond, it's certainly key that you isolate yourself from work, and that's been certainly clear from government guidance, unless absolutely essential. But from the point that some of you may be approaching labour and be very concerned about what this means for you in the hospital when you arrive. Well, it's very different, because a month ago we didn't have any of these PPE precautions in the way that we're using them now. But you could expect to be met by people when you arrive in labour wards, you wearing personal protective equipment. So any interaction with a patient within a metre, we have to wear personal protective gear, which is sad for us, because actually I think seeing someone's face is quite important in terms of interacting. But particularly for us, it's an important safety precaution to make sure we reduce that key priority, reduce the spread of the virus. So when you come in, you will be expected to attend labour with just one birth partner, so we can't have multiple birth partners, and this has been the general Royal College advice. A lot of the things I'm telling you today have come from our Royal College and are advice that most hospitals around the UK are adhering to. You will not be labouring alone. It's well known from lots of research that good outcomes in labour are related to having your birth partner with you. But you will be met by people wearing a lot of the personal protective equipment. And I know some of the staff in my department have put pictures of their faces on their aprons to try and make sure that people can see who's looking after them, which is a really nice thing. I think it started in Italy. Because I think there's a lot about someone's face and their interactions which tells you a lot about that person. And it's quite hard sometimes to communicate the kindness and relieve the anxiety that someone will have when, of course, they're approaching an uncertain labour and what it means with a face mask on. So that's incredibly hard. But throughout your labour, you'll be cared for with a midwife, a birth attendant, who will have a full PPE on, so gowns, gloves, and a mask. If you're yourself well and normal and healthy, you won't be expected to wear a mask. But if you are yourself unwell, and in fact, if you actually have the coronavirus or have been proven to have it, you will be expected to wear a mask. Certainly walking in the labour room and around. But would otherwise treat you entirely normal during the delivery. There has been some evidence from a lot of the Chinese reports that actually it's best to monitor the babies in labour, and so the college is recommending that you have continuous electronic fetal monitoring throughout the labour, and that's simply because there were people who are COVID positive and are symptomatic and unwell are more likely to struggle in labour, and that's why the monitoring of the baby is so important. So that's a very key thing that you may not know, which will change things. But a lot of monitoring nowadays can be done peripherally, so you can still remain very mobile, and it's absolutely key that you have the opportunity to do things as normally as possible. We want to keep things as normal as possible for you, and we want to still read your birth plans. We want to still understand what you want to do. People may have questions about water births. Water births are something which our hospital is still currently supporting, and if you are a normal and healthy and your midwife is willing, there are some people that will still support water births, but do inquire locally with your maternity team as to what exactly you are not able to do, because, as I say, regionally this will vary from hospital to hospital very, very, very marginally. In labour, if you're let's stick with being normal and healthy at the moment. You will literally be cared for, therefore, in a very normal way, with just somebody who is unfortunately hiding behind a gown and a mask and some gloves. All precautions will be taken through the labour. And if you deliver your baby and you're healthy, you should go through all the normal things of delayed cord clamping and skin to skin and all of the important things that are essential to bonding with your baby. If you are unfortunately in a position where you need some assistance, which requires you to leave your labour room and actually to end up in theatre, then things may change a little. You may meet more people wearing gowns and gloves and aprons. You will, certainly in our hospital, I know this is something which is being rolled out nationally, we're trying to support the fact that most birth partners will want to attend and be in theatre if they can be. And with enough PPE and enough equipment available, that's something that we're supporting currently in Bath. But you will need, again, to check with your local maternity team if you end up in labour, and you can ask that question. There's no need to ring up in advance. You can ask that on the day. If your birth partner is well, that is fine. If your birth partner has symptoms or has been unwell, then that is not fine, and they shouldn't come to the hospital with you. So you may need to have a backup plan if your partner were to become unwell. And it's always important to have these conversations in advance. In theatre, the only time a birth partner wouldn't be allowed to remain in theatre would be if it was an emergency which required a general anaesthetic, or an emergency which we wouldn't regard as being something that we would want the partner to see or to be part of. So, for example, needing to go to sleep is not something which we allow people to stand and watch in any case, but particularly during the coronavirus pandemic, birth partners would be asked to leave theatre if that were the case. And that's the same for any aerosol generating procedure, which is what happens when you have an anaesthetic and you go off to sleep. But general anaesthetics are really, really rare. I can think in my career, I've been doing obstetrics and gynecology for 15 years. It's very infrequent that we need to do them, and if we do need to do them, it's done very calmly. So most of the things will be as normal as they can be. The things that will obviously be important to you as well is what happens afterwards. Now, one of our key priorities, as I said right at the beginning, is to reduce the transmission. And because of the social distancing guidance that we have to follow, that does have an impact for you. For some women being induced may find that is different. So they, if they're certainly being induced in an open bay, most bays in hospitals are 4-bedded bays, you may go through a very slow, gradual induction process. Unfortunately, birth partners can't be present on the ward for that. So that is something to be aware of. And also, after you've had your baby, postnatally, as we call it, unfortunately, we can't have lots of visitors or birth partners on the wards. So those are the two things you might want to put some thought into, in terms of making sure you've got all your digital devices charged and ready and primed for the hospital, and you've got everything you need. So really think very carefully about that. Obviously, we would love for every patient to be able to spend those precious first few days and hours with birth partners on the wards if needed, but we just are not allowed to. So it's heartbreaking for us, and it's very difficult for patients. My understanding is that the support in the hospitals, certainly where I am, is still extremely good. You'll be given support with breastfeeding if that's what you wish to do, bottle feeding, and at all times we're trying to encourage you to remain with your baby as you would do normally. If you were to contract the coronavirus and become unwell, or for your baby to become unwell, then that may have a different impact on the course of events. And really, an hour webinar is too much to cover every single, I suppose, every single permutation and combination of different outcomes of what might be there. But obviously, neonatal care, specialist neonatal care, is available alongside every obstetric unit to look after babies if they require it on a daily basis. There's no evidence currently to suggest that if you have coronavirus and deliver your baby, that your baby will have it or become unwell, but there will need to be some quarantining taking place of yourself until your symptoms have resolved, and to make sure that your baby remains well. Your baby will be observed very closely. Now, I'm not a paediatrician, so I don't want to cut across the territory from obstetrician to paediatrician. There are far better people to give you the advice from that point of view. But my understanding is that testing is very difficult, as well as we've heard a lot about testing in recent months. There's often tests done which create false negatives. So you might have a baby tested and it comes out as negative, but it may be incubating the symptoms of the virus. So it's very important to observe your baby closely, and again, if you have any concerns about your baby, to obviously contact the assistants that were looking after you on the ward. But most babies, as I say, born to healthy mums, will not contract the virus. But it's very important after you go home, you still observe the same absolutely stringent measures of hand washing, cleaning bottles if you're preparing bottles, and making sure that you reduce any risk of transmission, direct or indirect, to your baby. If you do have the coronavirus, there's no suggestion that you can't breastfeed, but it depends on how well you are. And as I say, many people will be very well with this. If you do have it, you would obviously be concerned about transmitting respiratory droplets through the air in close proximity to your baby. So some people with the virus may be advised to wear a mask, one of the fluid resistant masks, but that would be discussed with you. So we're trying to keep things as normal as possible, but in literally a matter of weeks, we've gone from a very normal maternity service to one which has absolutely transformed and is trying every day to change and be resilient and be able to adapt to the new information coming through to us. So I've had quite a few questions, I think, put through over the course of the last week. I will just share with you that slide whilst we look at questions, just because there are some useful places to get a lot of your information from. So obviously we can only have an hour here to talk about certain things, but the Royal College is my college, the college which has a fantastic information hub for any of you that have any questions. A lot of the information I've shared with you today has come from there. They have a brilliant patient frequently asked questions section there for patients and women and their partners. So hopefully that will be of great help. And the same with the Royal College of Paediatrics and Child Health. If you have questions about the newborn, this is the place, I think, to look for your information. As well as that, you've got the government websites and the NHS websites, and of course, Wellbeing of Women and Total Fertility, which is a website I set up 3 years ago to help people looking for where to have their fertility treatment, and also we write a number of useful articles which we hope help patients, and there's one I've written on there, in fact, about pregnancy, which you might want to look at. So let me just move to some of the questions. If I can just find these, Janet, if my technology doesn't let me down. So first question is from Sally. What are your thoughts on pregnant women staying active during this time? I hope I've already sort of covered this. Absolutely would be my answer. It's really, really very important that you remain active, as active as you can, within the realms of the confinement that we're all having to experience. Whether that's physical exercise or just making sure that you're keeping yourself moving and not sitting down for hours and hours on end. eating well, and sleeping well, Sally. Those are all really, really important things. It's not maybe the time to take up new sports, but just take up things gradually as you can, and do what you can in the home. We've had a lot of fun at home here, going out with the kids that we have, and it's been really interesting for us to spend more time with them. So social isolation in some ways is good. You spend enforced family time together, and it's a great chance to do things like the Joe Wicks workout, although I would be careful if you're pregnant. So I've seen some of the exercises, they do look quite challenging. Let's move to the next question. Asma, quite a specific question on travel. This is about for Asma. The question is, I will be going at the end of July on holiday to Greece. I'll be 22 to 23 weeks pregnant. Should I be looking to cancel if travel companies start up again? Should we be going or not? It's a really impossible situation to predict travel at the moment, I think, and I've certainly myself had my last two trips cancelled, and I can't really see very much further ahead than next week at the moment in terms of things like that. And we know that we're going to be in lockdown for 3 more weeks. The travel companies certainly are. You have to be very cautious with any trips you are booking now, and insurance as well. Check your insurance policy. From the point of view of a pregnancy, our advice with travel, it generally is travel at your own risk, and be very clear, I guess, about where you're going. I think, as we always say in my job, plan for the worst and hope for the best. So if you can assume that you're going somewhere that you know and you're familiar with, maybe that's a safer situation. But travelling when you're pregnant would be a concern to anybody. But you might want to look at postponing to be completely safe. But I would hate for you to lose money on a trip that you've already booked. So it's a difficult one. I would urge caution, and it's difficult, as I say, making plans for anything at the moment. Next question is from Catherine. My partner and I are actively trying to start a family at the moment. What are your views? Any advice? And what should we do? Can we get on with life in this respect? Catherine, it's incredibly difficult at the moment for lots of people. The current advice really is that we don't think that this virus is having any impact, certainly in terms of harming the fetus in early pregnancy. So that means developing babies. It's a word the word we use is teratogenic, and we don't believe that virus has any harm to the fetus at that stage. So that's good. We're not telling people not to have babies. I work in fertility, and so it's always a concern telling anyone to delay their fertility, particularly because I work in IVF as well, and a lot of patients have not been able to go through with their IVF cycles, which is hard. We don't think this has any impact on miscarriage or early pregnancy loss, as I said earlier. I think you have to look at, and I don't know your situation, but you need to look at your age. If you think about somebody having regular cycles, menstrual cycles, then usually around 80% of couples will conceive within a year. So that's pretty good odds. So if you've never tried before, Catherine, and you feel that you think the risk is worth taking, I would say to you, absolutely, there's no harm. I don't think we've not got any evidence to suggest this is going to be an issue at the moment. Obviously, keep an eye on the data, but and we will try to too. But I would encourage anyone that's trying naturally to just continue as normal. Make sure you're taking your folic acid supplements and vitamins, and most of those things can be bought online, so you don't need to go out unless you're popping to the shops to get food and things. So yeah, absolutely, no reason not to. And I think if you are older, I would certainly suggest you don't delay, particularly because your opportunity to conceive once you get to 39 and 40 does go down. Next question. This is from Anouk. 2 questions. What is the risk of transferring COVID-19 to your newborn if you catch it after giving birth or shortly before? Well, as I said, the risks of transmission are by the 2 routes which we've discussed, because it's a respiratory sort of airborne virus, and it comes from the lungs. So the direct route would be obviously, I suppose, coughing over a baby or being within close proximity, and indirect routes. I think if you have active COVID-19, if you actually have it proven that you have the virus, then there is a risk that you could directly spread it to the baby. We think vertical transmission is probable, as I've already said from some of the China studies, that that there probably is some immunity being created in the serum of babies after they've been born. We're seeing that immediately there in some cases, but it's such small amounts of data. It's really too early to say how significant this is. I think the difficulty is that we haven't really got an optimal testing system in place yet, particularly for babies. I think if you're confirmed to be COVID-19, I would take the advice of the baby specialists to help you minimise the risk of transmission. Because if you wear a mask and you want to breastfeed, those two things should still be possible. But it depends on how well you are, I guess. But obviously, the transmission of the virus will depend on your stringent attention to hand washing and that. So let's go on. You've also asked how much at risk are newborns in general who show severe symptoms compared to children that are a few years older. We think, in general, again, that most babies will get a very mild infection or have no symptoms and be quite well. Probably the more at-risk babies will be the very preemie babies, potentially, and ones that may be immunosuppressed for some reason. So those are the two potential groups where things may be slightly higher risk. But again, if you are in that situation and you find yourself with COVID and you have a very preemie baby, those questions will be looked after by your expert paediatrician, neonatologist. Moving on to Raya's question: 33 weeks pregnant, and you have a low PAP-A and also gestational diabetes. So you're currently 33 weeks, I think, and you were given 2 extra scans to monitor the growth of your baby, but the NHS has said they would try their best to just give you the 36-week scan, and that you're a bit worried about your baby's health. Is there an alternate method to monitor the growth of a baby? So a low PAP-A result will require extra monitoring. For those of you watching who this is quite a specific question, but low PAP-A essentially is a marker that we pick up in screening, which, if it's very low, can be related to how well a placenta will work during pregnancy. And so for that reason, Arya, you've been told that you'll be monitored more frequently and have extra growth scans. Now, normally those are 3 weekly, and those scans will be done usually, certainly from you have your 20-week scan and from 28 weeks onwards, so towards the latter end of your pregnancy. First thing I'd say is I want to just stress the importance, as I already have, of fetal movements. So fetal movements are crucial. Keeping an eye on your baby's fetal movements, and if you have any concern about those, you must get in touch with the hospital, and we would see you as normal in the hospital to assess that issue. But that is one of the first signs, in fact, reduced movements of concerns with any placental growth. So that's why that's such an important sign for you to monitor at home. 3 weekly scans. If you're 33 weeks now, I would expect your next scan would be at 36 weeks. So it's good that they're going to give you a 36-week scan. I don't know if you were referring to scans after that or not, but I think those, if your scans are looking good at 33 weeks and 36 weeks, then I think you'll be absolutely fine. It's very important when you've got a combination of things, such as the low PAP-A and gestational diabetes, that you pay that enormous amount of care to your fetal movements and your sugars, keeping your diet as well controlled as you can to make sure you avoid high sugar foods. And I know you'll have had all that advice already. The only real way to measure growth is to measure your bump, which would be done by your community midwife and in routine appointments. But of course, we know growth scans are not infallible either. So it's important that, as I say, don't want to go back to the same thing, but your movements are absolutely key during this period. And if you have any concern, then do contact your maternity team. Next question is from Sarah. If I should contract COVID-19 whilst pregnant, does that naturally give the baby immunity, or will I still be classed as vulnerable? Well, Sarah, I think the evidence is evolving here. It's a fairly dynamic landscape. We're getting new information all the time. I think, obviously, if you have had COVID-19, you should be immune. That's the first thing to say. So I think you said, will I still be vulnerable? You should be immune. Probably, we think there's some vertical transmission to the baby. But again, this is something we still don't have all the information on. So that's a very difficult question to answer. I don't really have all the answers to that one, I'm afraid, Sarah. But I think if you've had COVID-19 whilst pregnant, you will likely be immune, and there's also a possibility that your baby will have got some immunity from that, from some of the studies we're seeing. But again, the significance of that still needs further investigation. This is a question from Mira. Can COVID-19 adversely impact on the baby? And what happens if I go into labour but have COVID-19? Well, we don't think, as I've said, that having COVID-19 while you're pregnant adversely affects the baby or compromises your baby in the womb. It depends very much on how sick you become, I think I would say on that point. If you do have COVID-19 and go into labour, you're very likely to be looked after and cared for in an isolation labour room. Most labour rooms are in, by nature, sort of single rooms. You're not labouring. Thankfully, we don't have rooms open with many women labouring all in the same room. So you have your own room. So you will be isolated usually, and it's essential that there are toilet facilities for you. So we're minimising the amount of movement that you might have from that room. You would be continuously monitored, and certainly that's the advice that we would regard as important. And you'll be given regular observations throughout of your oxygenation levels in your lungs, your pulse, your blood pressure, and your temperature throughout your labour. You will need to expect to be met by people in PPE and your midwife throughout the whole, of course, of your labour, and any contact you have with her in that room will involve full PPE. So if you go into labour and you have COVID-19, you can be reassured you'll be very, very closely monitored, and we will have patients who are suspected as COVID-19 as well, but not proven, and you will also be cared for in a similar way. The next question is from Helen. Do we have any data to support the impact of contracting COVID-19 on newborns and babies? There have been cases reported in the press of babies contacting it, including a newborn whose mother had it during labour, but there wasn't much information shared on the impact of the child. What I would say is there are 4 registries around the world which are collating data. There's one in the UK, the UK Obstetric Surveillance System, which is collating cases, and there's one in the Netherlands, there's one in the US, and these are all the time collating cases of COVID-19 in pregnancy and taking the data from that and then trying to put that into understand what's going on. The only one to really have reported actually is the Netherlands system, and that's given us, as we know, because we will see stuff, the stuff in the press you see, unfortunately, isn't the published evidence press that the doctors will go by. And of course, you'll see in the media, very sadly, cases where people have had bad outcomes. But actually, the way we can change practice is by focusing on the data, and the data is coming through these registries are showing really that the data is limited, but we think most newborn babies will be, again, quite well, and if anything, only have a mild illness. So I hope that answers your question. I think, as I say, the most susceptible newborn babies are probably the premature babies or those that may be immunosuppressed. Excuse me. 2 more questions. Excuse me. I've got 2 doctors questioning during 4 weeks. My husband will be working on the front line and exposed to COVID from the very beginning. We're keen to know what evidence shows so far regarding the effects of COVID-19 on newborns. As I say, you know, the registries are collating the data, and very few actual formal reports coming through. There's lots of case reports, but they're always quite difficult. A lot of them for China, so difficult to interpret. It's possible, I think, but not proven, that COVID-19 can be transmitted vertically in utero, and some immunity there. The proportion of pregnancies affected by this, we don't know. The significance for the baby, we don't really know. I think what I would go back to, however, to answer your question, is that we know that this RNA virus, this coronavirus, has not been found in amniotic fluid, breast milk, or vaginal secretions. but obviously vertical transmission is possible. So it's one of those difficult situations to know exactly what the data is telling us. Except if you have COVID-19, it doesn't necessarily mean your baby's gonna have it. There have been. Let me see if I just answered your question. What evidence? Yeah. I suppose you have to consider when you are looking after your baby, if you've had COVID-19, that potentially newborns may be incubating the virus. Again, that's where it's really key to keep a close eye on them. We would obviously expect small babies to be susceptible, but not necessarily the ones that will get really sick. So yes, your newborn may become affected after birth, but we think that most babies will remain quite well with that and not become sick unless they have other issues or complex problems. So in general, I think the data is telling us that it's a fairly minor illness. And the last question we've got from Tamara: are hospitals resorting to caesarean sections far quicker than normal? A friend of yours had a caesarean section last week, and she was the 4th member of her NCT group to have one. No other intervention was tried. Well, I can't speak for your specific situation, but I would say to you, as an obstetrician working in a maternity unit in the southwest of England, we are doing our absolute best to minimise intervention unless it's absolutely required. The normal rules of engagement are there for all of us to observe, and just because we have a coronavirus pandemic, we're not suddenly doing loads more sections. If anything, we're trying to reduce the number of interventions that we're doing, simply because we know the best way for women to labour is to labour normally without lots of interference, and actually interference only, or intervention only when required. So certainly not in our hospital. There's certainly no guidance from the college that we should be performing caesarean sections, certainly more. All I would say is with a caesarean section, there's always a risk you may need to go to sleep during a caesarean section, and that's the absolutely what we're trying to avoid. So what we are seeing in our hospitals is a very much consultant-led service, and certainly we have moved our usual ways of working with registrars and consultants on call, often from home overnight, is changing, and you're having what patients are noticing, and I think liking, is you're seeing a very senior level of senior registrars and senior consultants in the hospitals, making sure that every single detail is managed as quickly as possible to make sure that we're not ending up in situations where lots of people are going to theatre. So certainly that's my experience, and that has been my experience so far. Now, let me just look if there are any other questions coming in.
Ed, we've got lots of questions actually. Shall I read some out to you?
Yes, that'd be great. Thanks, Janet.
Okay. So the first one that came in was, I am asthmatic and epileptic and 33 weeks pregnant. I have a constant cough but no fever. Should I be worried?
I think if you're generally well and you feel that you've got a cough, I would keep an eye on it. The general advice is that if within 7 days that hasn't cleared up, or you feel like you're getting worse, then you would obviously want to contact someone, but you shouldn't be rushing to hospital. If you have just a cough, keep an eye on things. If you're finding that your breathing is becoming laboured, or your breathing is becoming difficult, or you feel like you develop a fever in addition, and start to feel that you're more laboured in your breathing, then absolutely you should be seeking extra urgent help. But currently, just from that 2 lines there that I can see, I would stay at home, isolate, and stick to all the guidance that we've talked about today.
Okay, and then from Beatrix, hi, may I please ask that once there is a vaccine, would it be recommended for pregnant women to have it?
I absolutely hope the vaccine becomes available to everybody. I think it's going to be absolutely key. I think the question of will the vaccine be safe in pregnancy itself is still to be answered. None of us know that. It will depend on whether the virus is a live virus that's being used in the vaccine, as I'm not going to be able to answer that, I'm afraid, as a sort of not a virologist expert. So my knowledge of vaccines is minimal. But there are some vaccines which are safe to have in pregnancy and some that are not, and it then generally depends on the antigen that's used in the virus. But I think we'll have to wait and see.
Okay, all right. From Stuart, hi, my wife is a medic and pregnant too. Should she still be going to work as normal?
Well, the general advice, Stuart, is depends on how pregnant she is. So if you are over 28 weeks pregnant, certainly that seemed to be the time where potentially if you were to get COVID, you're slightly more at risk. And therefore, if you're over 28 weeks, certainly our guidance has been that if you're over 28 weeks, you should be trying to socially distance. And so that can be quite difficult if you're working on the front line in a hospital. And so I'd say if she's over 28 weeks, then probably needs, I think some common sense needs to be applied, and probably that would be wise to discuss it with your occupational health team, and in fact the direct team that she's working with. Before 28 weeks, again, it's less likely that you'd become unwell. So it may be absolutely fine to go to work. And I suppose it depends what her role is as well within the hospital. An anaesthetist, for example, intubating patients during the COVID crisis would be at extremely high risk and in a much more risky position. So I guess it depends on her exact role, Stuart.
I think, if you don't mind, Ed, that we will have to stop there. We've got more questions. What we're going to try and do is answer those over email for people, if we can, with your help.
Okay.
Yeah, but I think we ought to stop because we have an hour. So it just remains for me to say thank you to Ed for taking time out of his work at the hospital in Bath to give everybody this talk. It was really fascinating. I'm sorry we haven't got through all the questions, but we really will try. And it just remains for me to say thank you for coming to us. And also, please do go on and donate to Wellbeing of Women, because the research that we do that you might help fund may well be, if it's not helping you, it'll certainly be helping the next generation of girls, women and families. So please do go and donate. It's wellbeingofwomen.org.uk, and it is still in the chat line as well. It really remains for me to say thank you very much. Stay well, stay safe, everybody, and we'll let you know of our next one. Thank you so much.
Thank you. Bye-bye.
Bye.